Thanks very much, Partha. Thanks very much, everyone. So what I want to do is present our real-world experience using Adalimumab, Humira, for patients with vision-threatening uveitis. The studies that really convinced everybody that Adalimumab was safe and effective were the visual studies, and there were 3 of them, and they I think, clearly showed a significant steroid-sparing effect, increased the time to relapse in patients who did relapse, dramatically decreased the frequency of relapse rates. They were safe, low risk of infectious adverse events. It's very important to exclude infectious uveitis. We need to treat latent TB before starting an Adalimumab, and it's also important to exclude MS because Adalimumab will unmask demyelinating disease. But with that knowledge, people have started using Humira around the world, and in many countries it's now licensed. Sadly, it's not in Australia. But we have had access to Humira for about 4 years, and we've also developed a registry, a real-time outcomes registry, to look at patients with uveitis and how they go. And what I want to do is just show you our early data from looking at the patients that we've treated with Adalimumab. I'd like to acknowledge my colleagues who have contributed patients, and Richard Symes, who's really led putting this uveitis registry together. So basically, across Australia, in the last 4 months, we've added 141 patients to our registry and have data on 261 eyes. Basically, we've followed them for quite a number of days, for some patients for 5 years plus, the entire time that we've been able to access Humira. And I'll just show you some of the data. So the disease spread is pretty typical for those that we've talked about here. There's obviously a significant number that have idiopathic or undifferentiated uveitis, but as they say, it's the usual suspects: birdshot choroidopathy, which is common in my part of the world, sarcoidosis, multifocal choroiditis, Behçet's disease, JIA uveitis, VKH, and inflammatory bowel disease, and some patients with B27-related systemic disease. And I think if you just look at sort of grossly at the data, you can see that there's really a very powerful steroid-sparing effect. If you look at the first dose and the last dose, 66% of patients are off steroids when they had their last visit, and 87% are down to a safe dose. If you sort of drill down more and look at patients where treatment was started within 4 weeks of their uveitis starting, we get this same similar powerful steroid-sparing effect. 65% of the patients are off steroids, and 86% are down to a safe dose. There were a relatively small number of patients where we had specific data at 6 and 12 months following the initiation of Adalimumab, but it's the same similar effect. At 6 months, really quite a large steroid-sparing effect. Half the patients off steroids, 80% of the patients down at a safe dose, and at 12 months, that effect is sustained, and similar numbers, 51% off steroids and 87% off steroids. Importantly, it also allowed us to slowly but surely decrease the conventional steroid-sparing drugs. We mostly use methotrexate or mycophenolate as our sort of first-line steroid-sparing drugs, and 75% of the patients were able to stop their methotrexate after 12 months of Adalimumab therapy, and nearly 90% of the patients were able to stop their methotrexate. In all the other patients, we've been able to reduce the dose to much lower levels than when they started. It certainly controls the uveitis, and 90% of patients had no anterior chamber cells. 88% of patients had no vitreocellular infiltrate. And importantly, if you look at vision, the most important thing is that basically Adalimumab stabilizes your vision. A small number of patients get significant improvements in vision, but the vast majority of patients, their vision just stabilizes, and only very small numbers of patients lose vision. And I think that's a really important take-home message from this, that the vision that you have when you start adalimumab is usually what you finish with. So the sooner and the earlier we're able to access a drug like this, the better visual outcomes our patients are going to get. As one would expect and predict, it gets rid of macular edema in many patients and probably, although we don't have the data yet, decreases the number of relapses. So basically, what I've shown you in this very brief overview of our data is that basically our data supports the earlier visual studies. It dramatically decreases the number of patients who lose vision. It stabilizes or improves vision in the vast majority of patients. It has a very powerful prolonged steroid-sparing effect and enables the majority of our patients to stop prednisolone therapy or at least get down to the current safe dose of 7.5 milligrams a day or less. And importantly, it allows us to decrease the treatment load, which greatly improves patients' quality of life. So I remember going to an American Academy meeting about at least 15 years ago, I can't remember exactly when Stephen Foster said that basically for uveitis patients, the mission is remission and the goal is durable steroid-free remission. And now I think we finally have a drug that will allow us to do that with most of our patients. Our registries have been going for a long time at the Institute. The uveitis registry we only bought online about the time of the AIOC meeting in Berlin last year, and this is our really earliest data. We've concentrated on just getting as much Humira data as we possibly can. But if any of you are interested in joining the registries, broadly they're across nearly 17 countries, quite a few countries in Europe, Australia, New Zealand, the UK are starting to use this outcomes registry. You do it online in real time, and after the first visit, it takes about 3 minutes to do a patient visit. So that's basically all I wanted to say. I'd like to take this opportunity to thank the organising committee for inviting me to speak here. I sort of invited myself because I came here as part of a Ransco College delegation to talk to the AIOS, and I twisted a few arms to be able to give some talks. So thanks very much. It's wonderful to be here face to face after all those years of Zoom meetings, and thank you very much, and thanks for being here. Thank you.
Thanks.